the Vice Chair, Councillor Kerry Lewis, and Karen Malpass from Democratic Services, who will be supporting us today. I'd also like to thank all the members and officers who are joining this meetings. There are no fire alarms scheduled this evening, so if you hear one, it's the real deal, and I advise you to make orderly exit. Please be advised that this meeting will be recorded and subsequently uploaded to our YouTube channel for public viewing. Members are kindly asked to raise their hands when they're indicating to speak. Scrutiny is the cornerstone of good governance. It allows us to hold decision makers to account, examine policies and performance, and ensure the voices of our community are reflected in the work we do. Our role is to provide constructive challenge, not to criticise, but to question, understand, and help shape better outcomes. Tonight, I encourage open, respectful dialogue and welcome contributions for all members and members of the public during the public forum. Today's agenda includes important items that deserve our full attention and thoughtful discussion. And so let's work together to ensure this meeting is productive and beneficial to the communities we serve. Thank you, and let's make a start with agenda item number 1. Apologies for absence. I have received apologies from Councillor Hanif. Are there any further apologies? Thank you very much. Agenda item number 2, appointment of substitutes. We welcome Councillor Sahota, who is substituting for Councillor Hanif this evening. Are there any other substitutes? Super, thank you very much. Agenda item number 3, do any members have any interest to declare under the Members' Code of Conduct? Speak now, forever hold your peace. I think that's okay. All right then. So agenda item number 4, which is to confirm and sign the minutes of the meeting held on the 19th of January and the 4th of February. Before we do that, would anyone like to raise any queries or questions with those minutes? So we're happy that those are an accurate representation of those meetings. Okay, I'm going to take that as a yes. And what I will do, we're going to have a short adjournment now to allow any of those observing the holy month of Ramadan to the opportunity to break their fast. So I will sign those the minutes of the meeting during that adjournment. If anybody is observing Ramadan and would like to take this opportunity to break their fast, please do so. You'll have 10 minutes to do that. Everybody else, if you want to have a cup of tea or stretch your legs or anything like that, please feel free to do so. And we'll reconvene at 6:15. Is that okay? Brilliant. Please be advised that microphones are turned off. Please ensure your microphones are turned off during the adjournment, because any conversations you have will be part of the broadcast. Just left it on the table. Okay, thank you very much for that. We shall now progress with the meeting, and we'll move on to agenda item number 5, the public forum. Can I remind everyone the purpose of the public forum is to provide opportunity for members of the public to raise matters of wider community interest that either relate to an item of the agenda or a topic within the committee's remit. It is not a question and answer session, nor is it an opportunity to raise personal or individual issues. These should be directed through the appropriate channels. Please note that as Chair of the Scrutiny Committee, I reserve the right to intervene and stop any inappropriate comments or questions at any stage. Do any members of the public in attendance wish to speak on any item on the agenda or a topic within the remit of this committee? Thank you. Councillor Cook.
Thank you for allowing me to speak tonight, Chair. I speak this evening as a father of a child with special educational needs. I know firsthand the fight that many parents face just to secure the support their child are legally entitled to. Across the borough, I hear the same story from families: months of chasing responses, endless paperwork, repeated meetings and constant pressure just to make sure the system is moving. Instead of focusing their support on their children, many parents feel forced to become negotiators simply to secure the help that the law already guarantees. I recognise the financial pressures that councils face, but legal duty around education, health and care plans do not disappear because budgets are tight. So my first question, if that's okay, Chair, what percentage of EHCPs in Dudley have been issued within the 20-week statutory timeframe over the last 12 months? My second question, how does the council monitor whether the support written into EHCPs is actually being delivered and what action is taken when it is not? Parents are not asking for special treatment, only for the law that's protecting their child to work in practice. Thank you, Chair.
Thank you, Councillor Cook. Welcome your contributions and recognise your strength of feeling on this topic. Just looking around the room, we have a representative from Public Health, and we have the shadow cabinet member for Children's Services in the room, but we don't have the relevant director or a cabinet member. If Councillor Ridney would like to engage on any of those points, but very welcome to do so. But as an offer, we would be very happy if you wanted to send those questions that you read out to Karen. We'd be very happy to get written answers for you, and we will ensure your contribution tonight is included in the minutes of the meeting. Councillor Ridney, would you like to engage?
Yeah, just to say it would be better to put them in writing and send them. I don't have that information, certainly not about the number that are completed in 20 weeks. It has been a failing in the system, but not just for us countrywide. I think we've got the same problems, but I would suggest that the questions are put in writing and sent to directly to the director for answers, because there's no one here with that sort of information tonight.
Thank you, Councillor Ridney, and thank you for providing a response. Councillor Cook, is there anything else you'd like to add on the topic? Thank you very much. Well, you're very welcome to stay for the rest of proceedings, but as you aren't a member of the committee, you won't be able to contribute. But you're welcome to remain in your place should you wish to do so. Thank you very much. Okay, on to agenda item number 6, which is the progress tracker for future business, and you'll find that between pages 41 and 51 in your pack. Thank you. So hopefully you've all found the progress tracker. This report captures actions from the meetings held to date and highlights progress. I note there is a response outstanding on pupils' deregistration figures from schools in the borough. Although we don't have anyone from the Children's Services here tonight to answer, but we will continue to chase a response on that point. I would welcome any other comments on the progress tracker and matters for future business from members of the committee. Councillor Baton? No, I thought you were going for the microphone. No. Okay. Anybody else? Thank you very much. So we'll take that item as noted, and we'll move on to agenda item number 7. Should we enter the twilight zone then? It's fine. So we'll move on to the review of the public health grant. You'll find that between pages 52 and 78. Could I invite Hema, Interim Director of Public Health, to present the report, please? And can I ask members to keep any questions until after the presentation? Thank you very much.
Let us turn. Thank you, Chair, and good evening, everybody. So the purpose of bringing this paper today to the Scrutiny Committee is to give a brief of the public health grant and the reasons why we get the public health grant, the statutory requirements, as well as our functions in terms of a good public health delivery system. It's come because we have been reviewing internally the processes of how we make decision-making on public health grant and how do we make sure that it meets the terms and conditions for which it has been given. There was also, we have been participated in the OHID review of most of the grants for 2 years before in terms of the processes. We have got the new allocations, which is consolidated for 3 years. So it's again looking at how we use that. And there are, within this consolidated, there are ring fence within the ring fence. So it's important to make sure that we are looking at that as well. So I have a presentation to go through the paper, and I hope that the paper that was written is of sufficient information and clear, but we can go through the presentation, which again tells the same story. I just start the slideshow. So what I'm going to, as I said, discuss is the context for the public health grant. So what are our public health responsibilities? How much is a public health grant for the next 3 years? What are the public health reserves? And I have to flag that I don't have the exact figures because they're still looking in terms of how much was spent, so they're consolidating that. So I'll give that later. I'll send it when it's available to me. The purpose and conditions, the eligibility of the grant spend, standards for public health system, and the key actions, as I said, from the internal and external reviews. And I think the scrutiny has a very big role to play in this, because you will have heard from various places that some of the public health grant was not spent properly, I should say appropriately, and then there has been issues in terms of either them, if they were spent in general fund for the council to give back from the general fund to public health grant, or if some councils, the DHSC, have taken a stern view of taking the public health grant back. So I think it's very important that we go through a process which is transparent and everybody's involved, so there's assurance. And I think, as the chair said, the Scrutiny Committee has got an important role to play in that. So the legislative framework for delivering the public health function, as many of you will know, but it's again good to re-emphasize that, is when public health function moved into local authority, there were 2 key functions, which is look for health improvement and health protection. Although it was delegated to AXA, we still have a big role to play in that as part of the national public health system. So the local authorities have a legal duty to improve the health of their local population, including oral health and public health in prisons, but there's also a specific mandate to reduce health inequalities. Although the Secretary of State has got the overall responsibilities, he may at times delegate more functions depending upon what the priorities are in terms of, for example, we've seen that with sometimes with the swap to vapes. Again, we got funding within the year to do some of that work. Health protection, as I said, is delegated to AXA, which is the UK Health Security Agency. But many of you will be aware, through the pandemic, local authorities played a big role in terms of managing that pandemic locally. So there is that still function that we have to deliver. So in terms of further legislation, the authority has got certain responsibilities which are written in the Health and Social Care Act 2012, that we do have to deliver the public health services. And again, there's section 6C of the NHS Act 2006, which gives certain conditions in terms of what are our mandated functions. So these are things that we have to fulfill, and we have to fulfill them in a certain way. So I think it's important that we understand the legislative function of why we are doing what we have to do and what the grant is being paid for. Now, I found this a very interesting quote within the LGA. As you know, the LGA do lots of guides for counselors. And I think this guide, this quote from that publication, and if you haven't had a look at the Counselor's Guide to Local Authorities' Public Health Responsibilities, I would definitely say it would be good to read. And they do also do webinars, etc. So they have said the public health grant is paid to local authorities from DHSC, as we know, and it is used to provide vital preventative and treatment services that help to support health and form part of the country's comprehensive health services alongside the NHS services. And some of these, as we know, were NHS services, which were smoking cessation, drug and alcohol services, children's health services, and sexual health services, which we do still work together with NHS because some parts of these services are commissioned by NHS. So we have to be careful that we are working jointly with them. So there is a pathway which is, and then the broader public health support across local authorities and the NHS. And I think this is very important because the wider determinants of health sit within the local authorities. So we have to be mindful about all these things that shape people's lives and people's health. And I keep on reminding Balwinder that the Director of Public Health is based in the borough, is employed by the borough, but they're Director of Public Health for the system. So it's not just for the local authority. So this was the public health grant in 25-26, just to remind us that we had around just over 25 million, which was to cover the mandated and prescribed services, as well as the non-prescribed services. I want to just emphasize, sometimes people get confused between mandated and prescribed. So mandated are things which we have to provide, but they're also prescribed so that we have to make sure that we meet the national service specifications, we meet the clinical governance and the clinical requirements that are there. So it's specified how we need to deliver that as well. So it's just not commissioning that, but you need to deliver them in XYZ way. The smoke-free generation, which I said came in from swap to stop, which was about reducing the harm from smoking. So people who were finding it difficult to smoke could swap their cigarettes for vapes. But the important thing over here is it is a harm reduction for those who want to quit smoking. It's not about, it's less harmful, so you can take up vaping. So that's another thing which we have to be careful about. The drug and alcohol treatment and recovery, we got extra money based on how much we're already spending on substance misuse. And then to remind ourselves that the Family Hub and Start for Life money that comes through the DFE to our education, our children's services, part of that money comes from DHSC. And therefore, some of those things, 68% has to be spent on perinatal mental health, etc., which we are very jointly working with our children's services to make sure that this is being delivered. And then we have the toothbrush 0 to 5. We are one of the local authorities which have been given this money, 89,000, because we participate in oral health survey. So not everybody gets this, but this is for supervised toothbrush, especially in the children which are in early settings in more deprived areas. So all this, except for the Family Hub money, has been consolidated into one grant for 3 years. As you can see that for the first year, we have just 27.5 million, 28 and then 28.5. But within that now they have ring-fenced the drug and alcohol funding and the smoking cessation funding. So if you count both of them together, you're saying around 23% of the public health grant has to be spent on drug and alcohol and smoking cessation. The other important thing that we have to remember is that this can be spent only on that. So for example, if we look at smoking cessation, it has to be spent on smoking cessation services and not on the NHS smoking cessation or the maternity smoking cessation services, because they get a different pot of money. So we shouldn't be spending that. And OHID have made it very clearly, how do they hold NHS to account if we start funding that, and they may then use that money for something else. And then similarly, if any money is underspent from this two ring-fenced money, they have to be put in a special ring-fenced reserve money. So if you don't spend, you can continue to keep it, but it has to be held within the ring fence of alcohol reserve money and smoking cessation reserve money. So to remind ourselves of what the mandated functions are, which we have to commission and have to provide in a special, the way it is prescribed. open access to sexual health services, services for drug and alcohol treatment, which I've said we have now got a ring fence within the ring fence, stop smoking or smoking cessation services, children's public health, which is the health visiting, and the school nursing service, which is our 0 to 9 services, which does contribute to the Healthy Child program. NHS health checks. So for those who, many of you may be aware of NHS health checks, they're basically checks for anybody who hasn't got a long-term condition, either diabetes or any of those cardiovascular risk. But this helps us to look at the risk in that particular person. If we do pick up a lot of people with hypertension or diabetes through this service, so they can be put on the right treatment. So it's early case finding. But it's also those who are at risk because of their diet or because of their weight or smoking. How do we help them to reduce their risk? So it's a population program which is reducing cardiovascular disease, which is one of the greatest reasons for hospital admissions and mortality across the country. And it is also one of the main causes of health inequalities in terms of public health, in terms of health outcomes. The childhood obesity surveillance, which is childhood height and weight measurement, which I know has always been controversial since it came into being, but this is part of a more higher, I would say, a global thing which WHO suggested to everybody, every country, to look at the height and weight of the children, so we can look at globally, we can look at how childhood obesity is increasing and what are we doing to support that. So part of that is a surveillance system, which like we do surveillance for infectious diseases, etc. So this is a surveillance system. And it has to be done in a sensitive way, because what we don't want to do is label anybody, any child, but it's about how do we then use that to have some population health services. We need to provide public health advice. As I said, public health is about the whole system. So we have a duty to provide public health support and public health advice to commissioners. So now it's the ICB commissioners, it was CCG before. So at the moment we are doing work with them in terms of integrated care needs, so that they can write their strategic commissioning plans. Provide information and advice to certain persons and bodies, which is really about, again, health protection. So if there is any threat to the local population, whether it's infectious disease or environmental hazards or extreme weather, we work with AXA and the LRF to support that mitigating or managing that incident. What are the other health improvement functions? Now these are functions, and within that there's quite a lot, but I've just sort of put them on the top in terms of, I mentioned obesity, but it's not just about weight management. How do we look at a whole system approach? How do we change our environments, the more obesogenic environment, so that we enable people? Because one of the big things about obesity is it is the way we live, it is the environment that we live in, and what we know is something not only for Dudley, but across the country and across the globe, I would say. You can go to the Himalayas and find McDonald's there, so it just tells the story of the commercial determinants of health. Physical activity is, again, big thing in terms of, we do know that a lot of people are physically inactive, and that's true for Dudley as well. And then other public health programs for children. Health at work is a very important one, which we are not dealing very well, but we need to think about that. Public mental health, wider tobacco control, health promotion, health service, which is about how do we get communities and how do we support communities. Now this I have brought because it's important to look at the public health grant in relation to all the other funding within the local authority. And you can see it's very small compared to everything else. And so we have to remind ourselves that the public health grant is not about how do we fund other things, but it's about how do you use it, more important to look at some of the mandated functions, but how do we use public health expertise to influence the others and use some of those public health approaches. And we are doing, for example, some work with Family First to give those public health approaches. So this just tells me, I just wanted to say to you, it's about not only about commissioning services, but it's about how do we deliver a good public health system and what are the standards for that. So the function, and it's important to remember what is the function of public health. I spoke about the legislative framework, but it's what is a function of public health system. It's health improvement, public healthcare, so, which is, I mentioned health services, but we also now support children's service, social care and adult social care, health protection, academic public health, because it's a lot about evidence-based, doing the research and looking at innovation and new ways of finding solutions to some of the problems. So how do we work with academia to make sure that some of what we have locally is dealt in terms of their research? Public health intelligence, which is all about needs assessment and evidence base. And then most importantly, also workforce development, because we need to make sure that we have a workforce which we are developing, which fits into public health. And there are standards again for that. And there's quite a lot of funding given across the country, but also locally. And we haven't been doing that, but that's one of the things I want to do is apply for that funding so that we have public health apprentices, just like we have apprentices in other areas. We can bring in public health apprentices, which means local young people can join their public health apprentice, have the opportunity to become a public health apprentices, where their fees are paid for their their bachelor's degree, as well as if they've got a bachelor's degree, then the master's degree in public health. They get training in terms of placements across the system. So the end of it, they actually get a job in public health. And I think we need to do that for our young people. And this is just a very quick thing in terms of evidence-based practice, because that's the other thing which I said, it's some of these services we need to be mindful that they are clinical services, but also the bigger public health picture, and the National Institute of Clinical Excellence does give guidance, does do evidence-based for that. So if you just do a quick thing, you can see there are 942 guidances, but there are also quality standards, which NICE does. And this is just a few examples. We know dementia is a big problem, and frailty is also in life is a big problem. And NICE has come out with evidence on what works for midlife approaches to delay the onset and prevent onset of this. So this is very important from that perspective, is to work with our working age population and our adult social care in terms of what are we doing for midlife approaches to delay some of this physical activity and environment. How can we make the environment so that people can become more physically active? There's again falls prevention in older people, tobacco, which how do we prevent, especially young people taking up smoking, but also now vaping. There's a maternal and child nutrition. I've just set some examples. You can see how much there is in terms of all of this. And the last one I just wanted to mention is about the quality statements. So they give quality statements of how you can use some of the information and evidence locally to start thinking about how are you reducing, for example, alcohol harms from alcohol. So this is quite important again for Dudley, because we do have a high mortality rate from alcohol, and we do have a higher admissions from alcohol, and we have the highest number of alcohol licensed premises, over 100,000 within Black country and in others. So there's something about, how do we do that bit of harm, and that it's not only for alcohol, but when you start looking at that, the impact of alcohol is, we know there's there is domestic violence, and domestic violence and abuse, which leads to children being neglected or abused, which then leads to the burden on our children's services. So there's something about, we need to think that whole picture in terms of, if we prevent and start reducing the harms from alcohol, using some of this evidence-based practice, how does that have an impact on our children's services? So what we are trying to do, just sort of again to say, if this is what the whole public health system should be doing and looking at, how are we embedding public health approaches across the council? So we are looking at working with our children and adult services to improve in terms of how do we work to improve a life course approach. So starting well to dying well, with communities and growth in terms of how is the regeneration using some of the data we have to make sure that we are improving our streets, our neighborhoods, etc. With housing, because that's again a big place, workplaces, and as well as looking at some of the intelligence data that sits within the council that we can start looking at. So I would now like to talk about, sorry, I just have some. About the internal review we undertook for public health grant. And the things that we sort of said we wanted to do was decision making. How do we prioritize in terms of how public health grant is spent? So do we have a prioritization framework, or how are we making those decisions? What is the governance? So how is assurance provided? Do we have transparency? And at the end of the day, the Section 151 and the DPH have to sign off the returns to DPH, to OHID, but how has this gone through the whole assurance process so it's transparent and we are clear in terms of what we are spending on and how we are spending? And that's why I brought this here today, so that, throughout the year, we can bring papers to the scrutiny as part of that assurance. The quality of commissioning and performance monitoring, because if we are going to improve outcomes for our population, we need to make sure that these are key services which have got quite high value, and what is the quality of commissioning and how are we performance managing that. And then there were the historic switches. For those of you who've been here for a long time, this was money transferred from public health grant to internal departments, and some of them started in 2014. And when we've been reviewing, we have kind of said, okay, people have left, people have moved around, and is this really switch for what it was meant, or have been the lapses because we don't know what's happening? And this was the external OHID public health grant assurance, where it was quite a lot of spreadsheets and things that we had to put in. But just giving you an indication, we had to say everything that we spend on public health service program or an initiative, who we are commissioning or where is that money going, whether it's a provider or internally. If it's internally, then which directorate did we give the money? And then map that to the categories, which, as you say in Appendix 1, I've put all the categories for spend, so which category does it belong to? So it was quite an in-depth analysis of a public health grant spend. So what this slide shows is the key learning and recommendations from those two processes. So the first one was that we really need to improve the decision-making process for public health grant to ensure there's transparency, value for money, and the assurance that it is spent in line with the eligibility of the spend, and we are meeting the outcomes. We need to reset the public health financial system in the business system aggressor, so that it does have correct spending categories, and we are applying a robust methodology for reporting. So again, we know exactly this is what we are spending, for example, on sexual health or obesity, etc. We need to develop a priority framework for maximizing population health and well-being outcomes for the diverse community. So if we are spending on A, we know there are opportunities cost, and we are not spending on B. So do we have a prioritization framework which helps us to make those decisions on how we are spending public health grant and on what should we be spending on besides the mandated services? Are we undertaking health equity audits as part of the comprehensive needs, which we haven't done, so that we know that we are reducing health inequalities as well? And we need to agree a transitional plan to end the historic switches to a 3-year internal commission services with clear public health outcomes and KPIs. And again, develop a 3-year financial plan. And I've said this to ensure 90 to 95% of the spend is really on things that we should be spending on. What we don't want to do is build up public health reserves, because if you build up public health reserves and you're not spending it, and it goes above a certain level, OHID and DHSC get concerned and they start saying, well, you don't need this much money because you're not spending it, so we'll take back some of the money. So we need to make sure that we are not putting in too much in public health reserve. So I'll stop here, but there are recommendations for the scrutiny which I've suggested, which you can discuss, and there are the actions, as I've said.
Thank you very much, Hema. Going to open up the floor for questions. Thank you. I saw Councillor Baton first, then Councillor Bridney, and then you, Councillor Creed. Okay, sorry, mate. Yeah, I got you. Don't worry. Anyway, over to you, Councillor Baton.
Thank you. I mean, I absolutely agree that you need to keep the reserves to an absolute minimum, because we've highlighted you've talked about the pressures, you've talked about particularly the alcohol issues within the borough. Now, if we're not spending our money properly on those services, there's a big question to be asked. And I think I feel from a scrutiny point of view, it's excuse me, it's quite a difficult ask, because what I would have expected, or what I would want, is to understand the categories which you've outlined, to understand the spend within those, and then to understand the reduction or improvements in the outcomes, to understand whether we've got our priorities right. So without that data, I mean, I can agree with all of the recommendations, and some of those are process recommendations, aren't they, that, scrutiny would never get involved in. But I think as part of a wider scrutiny piece, if we don't know the outcomes of the money that we're spending, we don't know whether we've targeted it in the right place. So that would be my overall observation with that. But I would like to just pick up on the switches. And I know for a number of years public health switches have been used, some with very loose benefits, shall we say. They've been made to fit rather than having a natural fit. So are you confident that you will move away or be able to move away from those switches which prop up other services to move it to more appropriate use so that we can actually see the benefits?
Just before you reply, Hema, I'm just going to say, just as a bit of housekeeping to the members of the committee, please feel free to ask as many supplementary questions as you like. You don't need to come back to me. I'm happy for you to keep on a line of questioning. Over to you, Hema.
So you're absolutely right about the first bit about you need all that information. And that's why one of the recommendations I made is that I bring in June, when we've done all that bit about, what we want to spend on, our business plan, what our priorities are, a prioritization framework, the data in terms of outcomes. I'm doing some return on investment from the services we've commissioned. So if you're spending this much, what are the outcomes? So that all needs to come here in June. But this is to say that this is the process, this is how we are doing it, and to make a recommendation, that's why I said to bring it in June with all of that information, because you're right, without that, how do you scrutinize? But it's the start of the process in terms of doing that. The second question which you said is about switches. So I have been having, the whole last year I've been having meetings with each of the directorates, and we have at the CMT agreed that it will be after the transition, it will be an internal commission services, so it's public health outcomes. So you can deliver public health outcomes to other services, but it has to have proper, just like we commission everywhere else, it has to be a properly internal commission services with KPIs and then monitoring and quarterly reports like we commission any other service.
And just an additional question, when we look at the internal review of public health grant slide, where you say about governance, how is assurance provided? Does public health not report into the Health and Wellbeing Board, so that because you have councillors who sit on that, so that would be the ongoing monitoring and governance and assurance processes, I would have thought?
So the Health and Wellbeing Board will look at the health and wellbeing strategies and outcomes, etc. But normally it wouldn't be the grant assurance that they do, because the grant is held by the local council, and whatever governance and assurance we have within the local government in terms of any financial planning, we should follow that.
Thank you. Councillor Ridney?
Thank you, Chair. I support everything my colleague has said. It has been, for the last few years, it's been very difficult to find out where the grant's been spent, because we've had a total lack of data, really. At the budget meeting I raised, where is our local ward data? I haven't seen any for years. Mine, I think it dates back to 2019, which actually tells us about the health of our residents, how many over-aged people we've got, how many children we've got with disabilities. We haven't seen that, and that's important to us, and that's how we can compare, and we've seen nothing. Is that going to improve, is my first question. I then looked through your appendix that was attached to the report that we had about categories for reporting local authority public health spend, and I noticed it says physical activity for children. Now, all play areas in the borough, as far as I'm concerned, should be inclusive of all children, but they're not. We've all had presentations at various committees. Oh, this area is going to have a new play area, and this is how much it's going to cost. But if you want it to be inclusive for all children, that should not be a consideration. When we say a play area, we shouldn't need to say it should be open to all children. It should be. We shouldn't even have to think about it. And I'm really sorry that we can't say that in this borough. It's embarrassing. Because what they're saying to you is, well, it's going to cost you 70 grand, but if you've got to make it out to it, it's going to be 100 grand. So what? You know, it's okay, Martin, I'm having a go again about the spending. It shouldn't matter. They should be open to all children. And how are we going to help children to be Steve if we haven't got playgrounds that they can all access? I think you've got a lot of work to do to bring it up to standard, or what we would consider standard. I mean, I don't think that your grant should be used for anything other than public health. And I'm going to have a go now about smoking. You know, we've just looking through the window from the Labour group room earlier, there were youngsters standing over the road in the bus, all with the little vapes. They were like dummies. We wean our children off dummies, and then we give them a vape, or we're allowing them to have a vape. We need to be doing more to encourage children not to start using the vapes, because there is as much danger in that vape as there is in the tobacco. And I don't think there is, all the research has been produced yet, but we should actually have a programme in the schools that public health should be providing. But you don't see it. When was the last time there was a presentation done in any school about smoking? I haven't heard of any, certainly for the last, just taking the last 12 months, there haven't been any. That's part of the public health job, to be out there. We shouldn't have people wanting to come and ask public health what they should be doing. We should be in their face saying, this is what we are providing you for. And while I noticed that it is reducing adult smoking tobacco, but it's not. We're not doing anything to stop them picking up those vapes. I understand that the vapes help adults who want to give up smoking to help them, but there are companies out there that are actually focused on youngsters. But it's not just down to you. Planning should be making its part. When you talked about alcohol establishment, we're always told when you come to plan, well, you can't complain about that because there's one round the corner. Why not? You know, it's because they're in areas where they know there are people with drinking problems. I'm sorry to have a rant, but now's the time. Let's get it back on track to where it was. Thank you, Chair.
Just before you respond, Tima, are you able to confirm if the national guidance from the NHS or Public Health England or the appropriate body is still that vapes are recommended as a part of smoking cessation? Or could you confirm what the guidance is currently around that?
Do you?
Thank you, Chair. Obviously, I'm just standing in. Obviously, I find this area pretty interesting. And I thank you for your presentation in terms of particularly referring to the key learning and recommendations slide. Now, I'm struggling here to understand clearly, in terms of obviously clearly there's recommendations there of what we need to do. I think what's missing is, why have we got these recommendations? Where have been the key failures, and who's accountable for those key failures and those action plans that have failed to deliver for our borough? I think that's the key thing we need to know, and also the accountability. And I think you mentioned social determinants, which are the key thread. All council services have an input into that, whether it's housing, neighbourhoods, parks, etc., public health, adult social care. So I'm really struggling here to see where's the sign up and where's the accountability to ensure that if we're going to deliver all these improvements, those key service areas are going to deliver. Now, Kathy and Sue picked up on a very important issue where green spaces in all our boroughs, in all our wards, So how do we hold neighbourhoods to account to ensure that the green spaces are improved, are those in the deprived wards? Because we clearly see out for ourselves, it's not always the green spaces in deprived wards where it's needed get the improvements. So this is where I'm struggling here. So it's all very well having this agenda, but then if that is not happening with neighbourhoods, or etc., or housing are not prioritising damp and housing conditions in the deprived areas, instead focusing on other areas, who's accountable? Because you're not going to deliver all these if neighbourhoods or housing are going in a different direction and doing the green spaces that they want to do because they got pressure to do it for X, Y, Z. So what I'm struggling here is how do yourself, with the senior officers in the senior management team, ensure that because we've got to this stage because it hasn't worked in the past. So we're going to carry on not working unless there's total commitment by senior officers around that senior management table saying, we're going to deliver this and we have to deliver it because X, Y, Z. Because otherwise we're just going around in circles. We're going to be in 5 years' time, you may be here or another director may be here, and they're going to be going through the same issue because I've worked in this kind of field before in another authority. We're just going around in circles without seeing any improvements. And I think as members, we don't want that for our communities. You as senior officers don't want that. So we need some clarity that we're going to get improvements and people will be working together to join the dots. I hope I haven't spoken out of turn.
Thank you, Councillor Zahota. Would you like to respond to the last two speakers, Seema, and then we'll come to you, Councillor Queen.
Okay, so I think if we spoke, I mean, the parks bit is the same thing, and we've been going around. So I agree with you absolutely in what you have said, and it is a huge task. And the last 1 year, and I said this to my CMT, that never before have I had to look at so deeply at everything that's going on because of the way it is. And that's part of the review that you mentioned is about, what do we need to do? And I have been taking a lot of that information to CMT so that they're aware and they're agreeing with, how we need to move forward. Part of this is, you're right about the physical inactivity, is how do you use all our assets, including our leisure services, to support children as well as adults. So it's whole families, take a whole family approach. So it's not just children, because children don't live on their own, they live in families. And sometimes they also are grandparents who look after children. So how do we, and grandparents need to increase their physical activity as well. So how do we take a more family-oriented approach using our assets? And that's why, when I showed that how do we embed, how do we work with all the core services, this is what we want to do, is not work, because a lot of things has to be delivered, and how do we as public health influence. And one of the things which I have noted, and thanks to Balwinder, she's given me the permission to bring in public health consultants, so now I have enough senior capacity, that there were a lot of staff which were didn't have that seniority and that experience and that expertise, who were doing stuff, but you didn't have what we call consultants in public health to drive that agenda and saying, this is what we need to do, these are the changes. So we are now picking up a lot of things which I said, alcohol is something which we've picked up. Physical activity strategy, it should be a universal service. There will be some targeted need as well for those children who perhaps need a more specialist form of physical activity. So we need to have all three layers of physical activity. We don't have a whole system approach to obesity. So we have some very fragmented programs going on all over the place, but we don't have, what do we need to do as a system? What are the priorities we need to take to change that obesogenic environment and yet support people in a way which is more normal rather than labeling as a fat club? So we are starting to take all of that information, and that's what I said, it needs to come in June, so you can see what we have prioritized, how we prioritized, and what we are doing on that with our business plans, financial plans, etc. And then that will help you to start looking at some of that work. In terms of the ward level data that you mentioned, that's again something which we are doing, which, so one of the things we are finding is that a lot of that comprehensive needs assessment wasn't done. But it's not only for us as a local council, we also are finding that the ICB needs data. So from our directors of public health, I've taken on the lead across BSOL and to say how do we come together, to work together, to look at an observatory, a public health observatory, which can cut data at different levels. So where ICB want to see things, they can see it at cluster level. Local authorities can see it at that level. And then within local authorities, how can you do it granularly? So we started that process as well, because you're absolutely right. If you don't see that at not only ward level, but within ward, there are deprivations and differences in terms of that. So how do we do that? We need to look at that. So that work we've started. You're absolutely right. So I said, I agree with everything you said. And that's why I think there is a lot of work to be done. And we are really working hard on getting this done. Plus, we also need to make a workforce. How do we, what I find is they've worked in teams in silos. So within Dudley, we know that people have worked in silos. But within public health, I have found people have been working in silos in their own teams. So again, we are changing it into more into a function-based system rather than a team-based system. So I hope that answers, and I agree with you that there's a lot of work to be done, but we are committed, and I have got a group of now senior people who are really committed to doing that. And we would be pleased to hear from, anything that we feel and when we bring it, we would want that feedback. But you're absolutely right, we need to use that in terms of that. And I think I answered maybe some of your questions as well. In terms of what were the failure, it's difficult to do any fault finding because some of these things have been going on historically since 2014. So it's more at the moment is about, so what was wrong and how do we improve that? So it's about learning from what was happening and how do we improve on that.
Yeah, just going to come back to Tony. He's a bit... Okay, thank you.
But it's actual factual. We talk about fluoridisation. That isn't down to you, I know. That's down to the water companies. But are they standardised across the water companies? Because it's important that we've not got the perfect dental service, and I don't know when we'll get a perfect one, but we haven't got. And children's teeth are suffering. I'm very glad to see that you're handing out the toothbrushes and all that. Keep that up, because it at least encourages children to. They come home very pleased with their toothbrush and their little tube of toothpaste. But I just wondered if it was standardised across the water companies. It isn't. Okay, thank you.
Okay, Tony, Councillor Creed, you've waited very patiently. The floor is yours.
True. Okay, so we obviously outsource a lot of the smoking prevention, drug prevention. What the performance of these groups, is it monitored?
I would say it's not monitored the way one would expect to. So that's why I said, there's something about how do we commission and performance monitoring. We need to improve on that. We have now started with the senior consultants going to the performance management. We've looked at the service specifications and KPIs. Are these the right KPI? So an example I'll give is once we started doing that in a more systematic way, we found when the services were transferred from one to another, there were data issues. And we've now got legal involved, and it's all been sorted. So there is improvement to be done, definitely, and we are improving on that because the KPIs should not be just service KPIs, they should be outcome-based as well, and they should be return on investment in terms of the value. So you can have, for example, a clinical service, which you have commissioned, which has to meet the clinical guidelines in terms of how it should be done. But when you look at the data in terms of how many people are coming into the treatment services and how many people in terms of the outcomes have remained in treatment and the outcomes have been good, then you start getting the return on value. So is this real? It's clinically sound, but if people are dropping out, then it's not cost effective. So those are the things that we have started to do in terms of performance management. It's just not looking at some very high level KPIs, but actually looking at that bit of information in terms of, is it also cost effective?
Are there tables, I'll say results for these organisations that are giving you, that are having I'll say, our money to run these courses?
Yeah, so the commissioners do attend. So one of the improvements that which I already brought is that we are inviting the providers to our public health DMT to provide data every quarter, so that their data analysts talk with our public health intelligence data to look at the data, the quality of data as well. Because sometimes you find that they will present something, but if you're an experienced consultant, you will say this doesn't make sense. They're showing that they're performing very well, but you can always see some things which you question. So we want to look at the data quality as well. And that's why I said we started this process. So when we come in June, we will be able to show those data dashboards in terms of improvement, in terms of what outcomes we're achieving, the cost effectiveness of those services. And that's why we are undertaking very comprehensive needs assessment, which will also have that information in terms of cost effectiveness as well. So it's a lot of work, as somebody has mentioned, because none of these services have had those comprehensive needs assessment, but the contracts have been rolled over. So at the moment they have been rolled over, but we need to do those before commissioning them out again, so that we have understanding of the cost effectiveness. We have understanding of whether it meets the needs of our population and what are the gaps. So it's not, and that's why I said there has to be a lot of improvement, and we started the journey.
Does poor housing come into your remit as well?
Okay, so housing doesn't come in our remit, but what we do is the impact of poor housing on health. So to give you an example of how we started work, we know a lot of respiratory conditions in children and adults can be due to poor housing. So we've linked in with the respiratory consultant and the pharmacist who is doing some very innovative work in calling from the GP practices, those who are at risk of admission. So it could be asthma, it could be COPD, etc. So, and he's doing the analysis in terms of just doing that. So as part of that, what we said, if one of the things is about poor housing, how do we link that with our housing team? So I've spoken to Catherine Jones to say we can put some money here. You mentioned about outcomes, so that there are clear outcomes in terms of what we are doing with that service, the two services, housing and respiratory, what they are doing in terms of what they are finding. So definitely poor housing has an impact on health. And how do we work with the housing services to do some of this work?
Anything else? Councillor Mason?
Thank you. Just really quickly, I mean, up till COVID, I was shadow cabinet for public health. And I have to say, the contracts that you're talking about, council agreed for the external contracts with drug and alcohol services, the requirements, the contract management was spot on. Now, I'm really glad to see that you're going to reignite this, but I think I have to raise a concern that between COVID and now, we seem to have got into some really lazy, bad habits that have probably A, cost the council money, but B, more importantly, cost our residents. So whilst I welcome this and I would support the recommendations you've raised, I am really concerned about that gap. Now, I can't change that gap, but I think it has to be acknowledged.
Thank you, Councillor Baton. Hima, would you like to respond to those remarks?
I think post-COVID, we do know that the recovery hasn't been, across the country, we know recovery hasn't been as good as it should be. So part of it was, during COVID, part of it is people have moved and left, and then new people have not picked it up as it should. So it's not perfect, but that's where we are making those improvements.
Thank you. I'm going to hand over to my Vice Chair who would like to contribute something around.
No, thank you. I'm going back to you, so sorry. And you was talking about vaping. As of 8:45 this morning, I actually received some information from my daughter's school about youth vaping and around safeguarding and parents and carers working together. Now, I don't know if you have seen this, but the fact sheet is fantastic. It's about 4-page long. The date on that fact sheet is from September 25. I don't know if you've set eyes on it or anything, But actually, I've actually sat there and I've read it all, and it is really good information to get together. Thank God I've never touched them, and I'd kill my girls if they did. But yes, so yeah, I don't know. Is that out to all schools? Do you know at the minute? Is that why I've got it? It was I was just literally just catching up on what Sue had said, because I was like, oh, I got my email this morning. So yeah, just following on that. Thank you.
So there is a lot of work that goes on with schools and public health, and vaping is one of those things. The other thing with vaping, you may have seen in the news with our trading standards, what we have found is not only the vapes so there was a piece of work done by the trust where some of the children who, look at vapes, and one of the things they found was some of them had illicit substances in terms of drugs, and I think they are being targeted to young people so that they can get hooked onto addictions, other addictions as well. So there is, vape is a big issue, not only in terms of from a smoking perspective, but from other perspectives. So we've had that meeting with trading standards, schools and others to do more work in terms of that bit. You will also have seen that vapes and some of these illegal vapes shops also are involved in, have got, crime gangs, and they are involved in exploitation of young people. So it's wider than just vapes. It's used as a hook to do a lot of other things. So how do we work on that as with partners in terms of some of these things?
No, thank you. No, it was just good to see, that's all. And I just thought I better back up the schools a little bit. Thank you, Councillor Rigney.
Okay, I can't see anybody else indicating to speak, so I'm just going to sum up some of the contributions we've had now, and then I've actually got 2 suggestions to add to the recommendations, so I'll mention those in a minute. But first of all, Hema, thank you for giving that report, and thank you for acknowledging the scale of the challenge. I think, and going forward, I think it's all of our responsibilities, all members, to help support you and your colleagues in turning things around. So with an aim to that, to support that, I'm going to suggest, if members agree, 2 things. Within the recommendations, I think as soon as possible, understanding you've got to have a lot of competing priorities, as soon as possible, we would like to see that ward level data to be shared, so we can all make informed decisions about how we best serve our residents. The second thing I would like to suggest in the recommendations is that we help you keep accountable for the spend in public health by having a quarterly update sent to either as part of the papers or sent to members of the committee, just to see how you're getting on with using those funds correctly, because ultimately what we don't want to see is our public health grant reduce over time. So I'm looking around the room. Should we just do it on a nod? Is everybody comfortable with those suggestions? So hopefully Karen's got those democratic services. But with that, I want to thank you, Hema, for presenting the report, and thank everybody for their thoughtful contributions. We'll move on to agenda number item number 8. Can I invite Laura Brooks and Wendy Ewins to present the report? I know. They've been waiting very patiently on Teams. So over to you.
Thank you, Chair. Thank you, Chair. You've all received the paper in the agenda item pack, but I'll just very quickly give you the highlight report. So we're here today to inform you about our proposal to stop providing specialist forensic step-down provision for men with learning disabilities at the Larches Hospital. So this is a service that's provided to men that have had a forensic background. They've got a diagnosis with learning disabilities, but they are in forensic services. This is not for people that are currently in the community or are at home. It's people that have been in a significant period of support for forensic purposes and are now needing to step down. But over recent years, and as a result of progress delivered through the Transforming Care agenda, which has been, I have to say, very ably led by Wendy, my commissioning colleague on the call, and Scott, my operational colleague as well, there's been a significant reduction in the number of referrals for locked rehabilitation beds across the Black Country, and it's quite clear to us now that there is no longer a cohort of men in secure forensic services who will require this part of the clinical pathway. There have been no referrals to the Larches in recent years from the Black Country because the demand for locked locked rehabilitation beds has essentially reduced, and actually there's considered to be an oversupply of male inpatient beds for this particular cohort of people across the wider region. As part of the Transforming Care agenda, you'll see within the paper in section 3.5 a whole raft of initiatives that are now available within the community support, including emergency response team, intensive support services, trauma pathways, all of which mean that we have a really strong community offer for people, meaning our use of beds has rapidly decreased over the last few years. In fact, we've seen now in the Black Country the most improved system, a national exemplar when it comes to learning disability support, and actually have seen a reduction of over 80% in use of inpatient services for our people with learning disabilities. This significant developments in the community has really enabled us to continue to reduce that reliance on inpatient care. And in addition to that, we have the Reach Out model, which is an adult secure provider collaborative for the West Midlands, which has a specialist community forensic service for people with autism and learning disabilities that work alongside those existing services that you've already seen me mention in 3.5, but then offer a community forensic services as well to people so they can have support directly at home. And they all start engaging with people 6 months prior to a discharge date that's been set to make sure that they get the right support that they need to come and work, be successful citizens in their local communities. In the very unlikely event that a Black Country citizen would require a locked rehabilitation service, we are able to still commission those, and we have strong links with Signet Cedars in Birmingham and Covebury Oldbury, Sandwell, that's a bit of a mouthful. One of which of those is required, is outstanding, rated by CQC, and are able to respond to new referrals. So we're confident that there is sufficient supply of male locked rehab beds within the region if they're ever needed. And those citizens placed in those hostels will still have the identical wraparound support as anybody currently placed at Larches if we were to place somebody there. So this really is a success story in terms of the journey that our LDA services have been on over recent years. As I say, ably led by Wendy and Scott, who are here to answer any queries that people may have. But what we're seeking today is support for us to cease that locked rehabilitation provision at the Larches that really hasn't been utilised now for a number of years. It's already been to scrutiny committees in other local areas, so within 2 of our other 4 places in the Black Country, and they have supported our proposal. So we'll bring it here today as well. We're happy to take any questions.
I can't see anybody raising their hands. I will manfully fill the breach and ask a few questions. Am I correct in thinking that other local authorities in the Black Country area have supported this already?
Yes, they have. Yeah. So it's already been supported at other scrutiny committees.
Yes, I knew that Samuel had, because I had a message from a colleague over there. But yeah, brilliant. Okay, well, I think that this is a huge step forward, and a big well done to you and your colleagues, Laura. I can't see anyone indicating wish to speak, so I think it is, on behalf of the committee, it's our pleasure to support the recommendation and the steps forward in mental health care in this region.
Thank you very much for your time. Thank you.
Thank you for coming as well. Okay, so moving on to agenda item number 9, and that is to the annual report and potential items for business for 26-27. The annual report provides a comprehensive overview of the work undertaken by this committee. It summarises the key activities, discussions and outcomes from the committee's scrutiny work, and sets out proposed areas of focus for inclusion for the coming municipal year. The purpose of the report is not to revisit matters that have already been considered by the committee, but I would like to invite members to put forward any comments or suggestions for the work for 26-27, just to say that we don't know the exact shape of scrutiny next year, but obviously there will be a committee that looks at the different areas that we have discussed. So yeah, I'll be taking items for a suggestion now. Karen. I can see Councillor Baton hot off the mark there. Go on.
Well, I'd emailed Karen a while ago with a suggestion, and she said, "Oh, bring it up at the committee," and I can't remember what it was. So you'll have to bear with me while I go through my emails or while Karen goes through hers. But what I did want to question was, is there going to be a recommendation at any point about the change or about an alternative committee structure, given how the number of meetings that this committee has had and the volume of work that has gone through it?
Absolutely. So, as you know, we've met, we've had informal meetings of the members of the Scrutiny Committee, and one of the discussion points that was raised at those sessions was the notion of changing the structure of the committee. That's something I would personally support, whether that's having a subcommittee to look at some of the items or splitting up children's from adults. I welcome if anybody has any concrete suggestions right here and right now about the future of this committee. I welcome that. But yeah, I do acknowledge that we've had to have a lot of extra meetings and a huge task ahead of us, meaning that we, right at the start when we were setting the agenda for this committee, we couldn't look at some items. So yeah, I would support rejigging the committee structure, but I don't have a concrete suggestion at the moment. Councillor Dale.
Thank you, Chair. This is probably more of an observation than a question, and probably shows my innate lack of councillor knowledge. As the controlling group, we obviously sit down and we have like interviews every year. Do the Labour side do the same with your group leader? But just going into the next year to see like what you've done, what your recommendations are, like discussions about committees, that kind of thing. Yeah, because obviously I think there was a few on our side that raised the overall kind of consensus that at the moment it's a lot and a broad spectrum of stuff, or albeit it crosses over at times, it's just simply too big a swathe of material to cover in one committee. I for one would like to see it split down. And because we've got some considerable knowledge in this room, it could be certainly utilised better across the two sectors. So yeah, I think that was definitely something that was brought up by many of us in our meetings with Pat. Sorry, with the leader. My apologies.
Leighton.
I found it. So what I'd sent to Karen was, and after I copied you all in, and obviously none of you have read it. Thank you. So what I was suggesting that we should have and whether we remain as a standalone, whether it splits again to adults and children's, but I think we should have a paper on complaints and ombudsman rulings for a given 12-month period. I'd suggest that we should have data for the complaints, compliance with timeframes by the authority and where there's any gaps, those upheld and at which stage and what remedy is offered, and those that progress to the Ombudsman and are upheld or partially upheld, and where, if they're upheld, where have we failed previously? Because that's the learning point really from the Ombudsman, is where we've previously failed and how we remedy that. So just that was my one suggestion, Chair.
Thank you. I think that's really welcome, and we do need to continue to be a lessons learned organisation, and that definitely helps facilitate that. Just to go back on the structure of the committee, I have, as I say, I would support restructuring it. I'm not here to represent the views of the administration, but what I think what they did, the thinking behind bringing it all together was to kind of follow a resident's life cycle through the scrutiny process. So we're looking at children and adults and thinking about how these services interact. So with that, coming back to splitting up the committees, there might be a value, I would say, in having a sub-working group with members of children's, if there was it to be split, children's and adults again, so they can share learnings. But yeah, absolutely. Over to you, Councillor Bevan.
Yeah, it's only a quick one. I don't have any suggestions on how to fix it, but it's just a small comment on sort of tracking the Dudley resident's life from sort of childhood to adulthood. and that didn't really materialise this year when I asked a question about ADHD assessment wait times for adults and how many of those children, how many of those adults have been waiting since childhood to get that assessment. So how many have crossed the threshold of being a child into adulthood before they got that assessment? But the response to that was, I only have data on the adults, but obviously there would have been children at some point. So just a comment from me on that, in terms of that joined upness hasn't always existed this year.
No, I take that, absolutely acknowledge that. And I think when we are looking at the shape of scrutiny, we do, we want to learn from this experience. And again, thank you all for working with myself and Councillor Lewis to try to make this committee work. So any thoughts and recommendations for the future would be, now's the time to get those together whilst we're preparing for our annual general meeting in May. Anybody else? Okay, well, obviously, please feel free to contribute ideas for the work programme for next year. I think the other thing I will acknowledge just at this stage, I think most of you have been copied into the email that I sent to our NHS partners, because there's a bit of an issue with the municipal year and the health year not lining up, and we want to ideally have some good scrutiny of the NHS quality accounts. So that's an ongoing piece of work, an ongoing conversation, and something that I'm trying to either, we might be able to look at that early data next month, or we might be able to recommend to the next, whichever committee inherits our responsibilities, that they meet as soon as possible to review those quality accounts. So with that, I'm going to move on. I'm going to close the meeting, but I will ask members of the committee to stay for an informal briefing from our guests from the NHS as well. Thank you all very much, and have a safe journey home.